Okay, well, today I'm going to be talking about myofunctional appliances and airways, and a little bit about facial growth and the impact on airways, and basically separating the myth from reality, because there's lots of claims made regarding airways and myofunctional appliances. So I'm going to actually go through the evidence that's available regarding these topics. So my name's Peter Miles. I'm an orthodontist. I trained dentistry in Australia. I trained in orthodontics in the United States in the University of Pittsburgh. I've lectured in Australia and internationally, an invited speaker at the American Association of Orthodontists on several occasions, a keynote speaker at the British Orthodontic Congress and other congresses around the world, and authored over 50 subjects or papers in various journals, as well as book chapters, and a reviewer for a number of journals, including the big orthodontic journals, the American Journal of Orthodontics, and I'm on the editorial board of the Angle Orthodontist. So that's my background. So talking about myofunctional appliances and airways, and as I said, there's a lot of information on the internet, and unfortunately Google is not necessarily the most reliable source of information. It can be, but when it comes to lesser known topics, this sort of information is aimed at the consumer, the patient and the parent, not to the actual orthodontist who's the expert in the area. But they'll make claims that are mixed up between some truths and some misleading information. So things such as mouth breathing is abnormal. It's one of the causes of sleep disordered breathing, and research shows that it stops the child's jaws growing normally. Well, they've mixed up some basically correct information with some misinformation there. But it's concerning to parents. You know, as a parent, if you're reading that, you're worried something's wrong or going to go wrong with my child. And some have suggested very early treatments. 5 to 6 years old is a very common time that some suggest for treatment, but some are even suggesting you need to be treating at ages 2 and up. So it's aiming at very, very early interventions, but what evidence is there to support these claims, and is it really true? Should you be being worried as a parent? Now, there's lots of different myofunctional appliances available. These are just some examples, things like the Occluso Guide, the Night Guide, the LM Activator, the MyoBrace, and the T4K, or Trainer for Kids. But they're not new to orthodontists in particular, because we've been familiar with appliances like these for many, many years. This is an appliance called a Kessling Positioner. It was used back in the 1940s and 50s, and in fact still used today for positioning teeth. But the design is actually very, very similar to a lot of these appliances. It's made postured into an anterior position with the teeth more lined up. And the idea of it is to wear it on a regular basis to align the teeth better, and in the case of myofunctional appliances, to try and improve growth. But the claims that they make on their websites include things like improved facial growth, skeletal growth change, so they will actually grow your jaw more than normal. You will get a better alignment because of that, and it will also, they claim, be more stable, because apparently they're improving some of these breathing issues or early growth problems. So these are the claims that are being made, but what evidence is there to support these claims? So that's what we're going to look at now, is the evidence regarding these sorts of claims. And we can look at some of the big journals like the American Journal of Orthodontics. This statement was in an abstract. It says, treatment in the early mixed dentition with the eruption guidance appliance is an effective method to restore normal occlusion or bite and eliminate the need for further orthodontic treatment. Sounds pretty compelling. This one from the European Journal of Orthodontics, again, one of the big journals. The PFA, or preformed activator, one of these myofunctional appliances, was the preferred approach for reduction of a large overjet or protrusion in mixed dentition or children. So since it minimized costs and there were no differences in the clinical outcomes between that appliance and an activator, which is a custom-made appliance. This was a summary in the Australian Dental Journal, and they stated that compared with traditional functional appliances, preformed activators might be more cost-effective. And this one in the Angle Orthodontist, also one of the big journals in orthodontics, early correction of increased overjet, overbite, and class 2 molar relationship, or basically the bottom jaw and teeth being back, with the eruption guidance appliance is maintainable and can also be effective in the permanent dentition. So that's treating kids and adolescents, or even possibly adults. So it seems, based on these statements from these big journals, that the case is closed. We should be using them. They are effective. But what unfortunately you need to do is read more into the article rather than just the abstracts and conclusions. And unfortunately, as an orthodontist, we see some of the problems that are being generated from misuse of appliances. Now, this patient had had 2 years of myofunctional treatment, and she's left with a significant protrusion and also a significant asymmetry. Her midlines are way off. Her bite on her left-hand side, where the red arrows are, is totally out. The top arrow should be back where the bottom arrow is, whereas on the right-hand side, the bite is almost where it should be. So she has an asymmetry, a marked asymmetry. An appliance like a myofunctional appliance was never going to correct that. That needs asymmetric mechanics with fixed appliances or aligners and elastics by a specialist, preferably an orthodontist. So we need to look closely at these articles of what the actual statements are, because you can look at the conclusions and the abstracts, but let's have a look a little bit more detail at what they're actually finding. So this is going back to the article from 2008 in the American Journal of Orthodontics on the eruption guidance appliance. Now, firstly, they had almost 1/3 of the sample were not included. So that's what's called selection bias. You're selecting the cases to present, and therefore they're the best ones, the best case scenario. And these kids were treated quite young, at age 5, with 2 to 3 appliances. So basically, they were treated over 3.3 years, which is quite a long treatment. So between the ages of 5 and 8. And they got a net change in what's called overjet, or the protrusion, by 2.4 millimeters, which is quite small in terms of orthodontics. You know, often we're dealing with protrusions of 5, 7, 10 millimeters or more. So quite a small change, and the overbite, or the overlap, the vertical overlap of the front teeth, was only about 2 millimeters. So again, quite small changes. This is an article from the Angle Orthodontist looking at the LM activator. The age group was 7.5 years, and the second group started at age 9. And this is the one where they said the early correction of increased overjet, overbite in class 2 is maintainable and can be effective in the permanent dentition, provided they keep wearing it regularly as a retainer. So they need to keep wearing the appliance. But the actual correction they achieved in that time was only 1.7 millimeters in the overjet, or protrusion again, and only 0.8 of a millimeter in the overbite or overlap. So very small. Even in the really good compliers, the best compliers, the best of the best, it was only 2.2 millimeters change. So again, quite small for, a year of treatment. This article, which was in the Journal of Pedodontics, was 43 subjects, again treated quite young at age 6, treated a bit over a year, an overbite correction of 2 millimeters, an overjet or protrusion correction of only 1.6 millimeters, so really quite small. This one in the Angle Orthodontist, 20 patients, treated a bit over a year, a bit older at 9.5. This one they looked at the skeletal changes. Were they growing jaws? And they found no. There was no skeletal effect. They were just tipping teeth. The upper teeth tipped back a little bit, the lower teeth tipped forward a little bit, and that's why you get these small changes in the overjet or protrusion. And this one in the European Journal of Orthodontics, 48 subjects. Again, in the abstracts, they record the mean protrusion, overbite, overjet decreased significantly, and the lower crowding decreased significantly. But if we look at the actual amounts of change, again, they were quite small. 2 millimeters of change in overjet, 1.8 in the overlap or overbite. And then they've also made the claims that it's stable. And then also, can you treat it later? And orthodontists know, yes, you certainly can. We deal with overjets or protrusions much larger than this in older kids, very successfully in adolescents, in their early teens, and even in adults. And knowing that, would a parent or patient consider a 2 millimeter change worthwhile, particularly when some of these treatments are going from 1 to 3 years? So if we were to cut one of these appliances in half, as I said, they're very similar to the positioner appliances and even double mouth guards that are made for some athletes. But if we cut it in half, we can see where the top teeth and bottom teeth are meant to fit into the appliance. So somebody with protrusive top teeth and perhaps their lower teeth are tilted back, if they're biting into this, that rubberized material will want to push on the teeth. And will tend to want to push the upper ones back a little bit and the lower ones forward a little bit. We also have to remember that they've postured their jaw forward, because if they've got what's called a class 2 bite, where their lower jaw and teeth are back, as they posture their jaw forward to bite into this, their jaw naturally tends to want to go back, which also pushes the appliance into the lower teeth, pushing them forward, and again pulls the appliance back, pulling the upper teeth backwards. So the upper incisors or upper front teeth will tip back a little bit, the lowers will go forward, and that is what reduces your overjet or protrusion. And because the back teeth don't touch, the back teeth can over-erupt, come down slightly. And so now we see a reduction in the overbite, or how much the teeth overlap at the front. So we can see why these appliances have the effect they do. But they've also made the claim that it's more stable. Now, there's not a lot of information on that, but this article from Guillermo Jansen in Brazil was published in the American Journal of Orthodontics, and they had 3.6 years of treatment. And again, about 1/3 or 35% of the sample was discarded. So again, we're looking at the best case scenario. And again, the overjet, the protrusion reduced by about 2 millimeters, but it relapsed a little bit. So for 3.6 years of treatment, you got 1.5 millimeters of change, quite small. The overbite, again, reduced by about 2 millimeters, but it relapsed almost back to where it started, to 0.5 millimeter. And the lower incisor crowding improved again by a bit over 2 millimeters and relapsed pretty much right back to where it started. So for 3.6 years of treatment, they got a net change of 1.5 millimeters in protrusion or overjet. Not impactful. Now, other studies have compared custom-made appliances, an appliance called an activator, with some of these preformed appliances. In this case, they were comparing a T4K. They're available in a limited choice of sizes. They're a pre-made appliance, as all of these Myofunctional appliances are, and you select the one that seems to suit the size best for the patient, whereas the activator is custom-made for an appliance and is more common in the Scandinavian or Northern European countries. And there's a lot of different functional appliances. A more common functional appliance in the UK and Australia, for example, would be the twin block appliance, which is more highly researched. But this study was looking at the activator and the T4K. And they found the activator caused less discomfort than the trainer for kids and was more acceptable. And that's understandable because it was custom made to fit them. But because of that custom made, they are a bit more expensive. Now, comparing the appliances, they found the activator showed a better skeletal improvement than the Myofunctional appliance. So it's leaning towards the custom-made appliance in that it improved the facial convexity better, and the soft tissue profile was improved only by the custom-made activator appliance. And the overjets were improved, again, not an amazing amount, only 3 millimeters by the activator and 1.5 millimeters by the T4K, but it is leaning towards the activator. But they did follow that up. Other studies have looked at appliances like the activator versus the MyoBrace, a slightly different Myofunctional appliance. And again, found that the activator appliance achieved a better molar correction. So it was doing a better job, but there was high non-compliance in both groups. About 70% of the preformed activator or the Myofunctional appliances were non-compliant. They weren't wearing them. And that makes sense. It's not made to fit them. It's not going to be as comfortable, so they're less likely to wear it. But a bit over half of the custom-made appliances were also very poorly worn. So that's quite concerning. As compared with other studies, most studies find around about 80% compliance. Another study by the same researchers looking at a functional appliance versus the preformed functional appliance or Myofunctional appliance versus an activator, they found the overjet relapsed more in the activator group. So long term, they ended up about the same, about that 2 millimeter mark. And that's why when they looked at the cost analysis, if you're only looking at about a 2 millimeter change in both groups and the preformed appliance is cheaper, then that minimizes costs. Now we've got to remember though, they were comparing it with the activator, which was initially invented by Viggo Andresen. He was a Danish-born orthodontist who later moved to Norway and trialed it on his daughter. During summer, she grew a bit, the bite improved, he noticed a change, and so he spoke about it, and it became quite a popular appliance amongst orthodontists, just showing cases that worked. And it was becoming widely accepted in Europe. So as I said, common appliance in Northern Europe, and that's what they were comparing against in a lot of these studies. But we know when we look at other very well-designed randomized clinical trials of appliances like the twin block, which is more commonly used in the United Kingdom and in Australia, the average protrusion or overjet correction was 6.5 millimeters, but anything from 3.7 to 10 millimeters. So significantly bigger reductions in protrusion with these appliances in these really well-designed clinical trials. And the compliance rates are substantially better at 84% in this particular case versus the 50 to 70% non-compliance in those other studies. Now, this is a patient of mine who I treated at that stage with a twin block, and she has a significant protrusion, and here she is with her appliance in place, basically posturing the mandible forward. It was custom made to have some expansion in the upper arch and then activating the wire at the front to retract her front teeth to get it to this point here. Now she's still got several baby teeth left. So we're just maintaining that, 9-time wear, and over time her other teeth coming through, but the bite is holding up very well. That protrusion hasn't recurred, but as other teeth have come through, they come through a bit crooked. And that's why most cases who have an early form of treatment will usually follow it up later once all their teeth are through with braces or aligners. So it can certainly make a difference for most people. But some people don't grow well, don't have good compliance, and so therefore they're going to need more correction of their protrusion later on as well. But you get good compliance, a good case that's selected by a specialist, and you can get a great outcome. But on average, all of these myofunctional appliances are showing a reduction of about 2 millimeters in the overjet or protrusion, 2 millimeters in the overlap or overbite, and 2 millimeters improvement in the lower crowding, which weren't stable. We saw that only the overjet maintained a bit of that, about 1.5 millimeters, for treatments ranging anything from a year to 3.5 years. So for such a more small change over that period of time, would you consider it worthwhile? And that's why most orthodontists don't use these. And it demonstrates the difference between what's called statistical and clinical significance. Yes, in these studies, they said in their abstracts and their conclusions, they were statistically significant. They asterisk it. But the change was only 2 millimeters. And clinically, that's barely meaningful. It's not really worth treating for a year to 3.5 years for 2 millimeters of change. And most patients wouldn't consider that worthwhile. So what's also mixed up in this discussion is airways and orthodontics. A lot of claims made about the impact of the airway and facial growth. And so we're going to look at the evidence regarding that. And if we go back a number of years to the show The X-Files, we know the Scully and Mulder characters that he was often saying that the truth is out there. But he always had that counterpoint with Scully, and I'm more with her in terms of, yeah, the truth's out there, but so are the lies. So is the misinformation. And unfortunately on Google, there's a lot of that in some areas. Maybe Bart Simpson's got it right. You know, the truth isn't out there. You've got to go and talk to somebody who really knows or is an expert in this area. And unfortunately, lots of misinformation. There's this particular group, IFL Science, spoke about these 4 journals that accepted a fake study about midichlorians. So if anyone watches Star Wars, they know midichlorians are just made up fictitious microscopic particles that allow the Sith and Jedi to have their supposedly magical powers. But it's totally fake. And yet these supposed journals that appear on the internet accepted this fake article as though it was real. And unfortunately, there's a lot of these predatory journals around nowadays that basically just publish things on the internet and sometimes even charging money for it, purely as a source of a way of getting information out. And some people will put their information out there just so they've got their opinion out available on the internet. But it doesn't mean it's a good source of information. And you're going to come across websites that make claims like crooked teeth are typically associated with narrow jaws and poor breathing. A narrow, restricted airway can impact on your child's ability to sleep at night, leaving them tired, difficulty concentrating, and often hyperactive. Now, there's some truths here mixed with some information, and that's the concern. And the child's attempts to adapt to these breathing problems can affect their teeth, posture, and development in nature's correct way. So it sounds very holistic, but again, what's the evidence? Because airway problems are a concern, but is it going to impact on facial growth? And if so, how much? And on YouTube, we can find statements like this one: that boy is a sick child. The statement's made, how do I know he's sick? Because he has crooked teeth. Now that's alarmist. That's making a parent think that the crooked teeth means my child's sick and we better seek treatment. But is that true? And this individual saying that mouth breathing has a negative impact on our teeth and facial development. Well, if that was such a concern, then why didn't he get his own teeth fixed? And unfortunately, again, as orthodontists, we see problems, cases that are poorly handled. This patient had 5 years of treatment and 9,000 Australian dollars of treatment spent in that time, which was well more than what my fee would ever have been for a complete treatment. And he's left with a significant bite problem. His top jaw is too wide compared with the bottom jaw. Very hard to correct that later on when it's been overexpanded. The lower teeth are still crowded. He's still got a significant protrusion. And worse still, he's burnt out. He's sick of treatment, and you need cooperation to get a great result for someone. They need to be on board. And he's just sick of having had 5 years of treatment. And financially, the family's spent. They've used up their health rebates. It's a lot of money to spend on this sort of result. So there's an emotional and financial harm being done. But unfortunately, there's also claims that even as an adult, we can still develop those arches to their genetic potential. And we'll see patients like this adult who had this sort of treatment done. Again, overexpanded in the upper arch, where it is now stable in the upper arch, but the problem is the lower arch is very unstable to expand. Now, she's had plates to expand it, but her bite is so unstable that the dentist ended up building up these plastic bumps on her back teeth because her teeth weren't contacting. So now she's left with a permanent open bite where her front teeth don't contact, as well as these composite bite ramps that she's just dependent upon, as well as financially having spent a lot of money on treatment. But can we expand it? Yeah, we can expand, especially the upper arch, but the lower arch we can't. Because in the upper arch, particularly in children, we've got a pattern suture that we can still expand. The bone's more malleable for the bones that support the upper jaw or maxilla. But the lower jaw, that fused together before you were even 1 year of age. So if you're expanding in the lower arch, all you're really doing is tipping teeth. And all the research we have on stability shows that as soon as you expand beyond 2 to 3 millimeters, yes, you can expand it, but it will always go back to within that 2 to 3 millimeters of where it started. So it's that lower arch that's determining what we can do in the upper arch. If you've got cross bites where your top jaw is too narrow and biting inside the bottom teeth, yes, you can expand that and expand the lower maybe 2 to 3 millimeters, and the upper will remain stable most of the time to that expansion if it's been done at the right age. But expanding the lower arch will be unstable beyond that 2 to 3 millimeters. Now, the other claims that are made that you need to go in and check your child while they're asleep. They should have their mouth closed and their lips sealed. And this is implying that if you don't see that, something's wrong. But is that true? Now, it's an example of a detection or an observation bias. You've been made aware of something. And when you're made aware of something, you notice it more. So you're going to notice these things if you've been told about it. You're going to look for it. You know, anything new in your life. You know, if you're building a house, you'll notice as you drive around the roofing displays, or you're going to look at house colors and the gardens, how they've laid things out. Or if you're having a baby soon, you see the families pushing their prams and out with their child, and the baby shops. You know, those things were always there. It's just your awareness of them has been altered. You know, you've got a different interest level now. So it's the same for this. If you're told to go and look for it, you'll look for it. And you might start noticing things. But were they worth noticing? And the problem is people who believe in some of these claims or statements also fall into what's called confirmation bias. And confirmation bias is the tendency to search for things that support what you already believe. If you believe something, you're going to discount the information that doesn't suit what your belief system is. You're going to look for information that supports what you already believe. And what we really need to be is more objective. Try and just look at the evidence and discount what we already think. But when we're, you know, subjective, we're thinking about our emotions. You know, for example, when you're falling in love and your partner's the perfect, beautiful Adonis, you know, everything's perfect. You know, they're wonderful, and you've got these rose-tinted glasses on, they look fantastic. And then we start to, you know, longer into our relationship, things become a bit more real. You know, well, actually a geek's an enthusiast, whereas a nerd is more of a specialist in a particular field. Well, luckily, my wife, I'm a geek and a nerd, so isn't she lucky? But it's true in terms of how we interpret things, our emotions interpret things, but we need to try and be objective and look at the actual facts. Now, snoring. Snoring is a sign of potential obstructive sleep apnea. but it's not diagnostic. Just because someone's a snorer doesn't mean they've got sleep apnea, but it's a sign. A high BMI or body mass index, basically a sign of being overweight, or a thick neck. These can be indicators of being at risk for sleep disordered breathing and sleep apnea. But there's also screening questionnaires that can decide or help you determine if you're possibly at risk. Again, they don't determine certainly that you've got sleep disordered breathing or sleep apnea, but they can be a guide. Things like the Stop Bang questionnaire for adults and the pediatric sleep questionnaire for children. And dentists and orthodontists can use that to screen for possible referral, if there's further indication required. Some of the questions on the pediatric sleep questionnaire include, do they snore more than half the time? Do they always snore or snore loudly? Do they have trouble breathing or struggle to breathe or have heavy or loud breathing? And have you ever seen them stop breathing during the night? And you're circling yes, no, or unknown, or some of the time. And do they have a tendency to breathe through the mouth during the day or have a dry mouth on waking? Occasionally wet the bed. Do they feel unrefreshed in the morning or have a problem with sleepiness during the day? And has a teacher commented that they see them sleepy? Is it hard to wake them in the morning, or does your child wake up with headaches in the morning? Did they stop growing at a normal rate for a while, or is your child overweight? And finally, does your child not seem to listen? Are they inattentive? They have difficulty organizing tasks or easily distracted? Do they fidget with your hands or their feet? Are they on the go or seem like they're hyperactive? Or do they interrupt or intrude others, butt in conversations or games? Now, a lot of parents might think, well, isn't that the typical child? And that's why there's got to be a number of yeses to these questions. So if they answer yes to 8 or more of these questions, then your child's at risk of sleep disordered breathing. And then you can consider bringing that to the attention of their doctor, their pediatrician, or an ear, nose, and throat surgeon. But it doesn't mean they've got sleep disordered breathing. It means that they're at risk. In fact, it's better at screening those who aren't at risk. If they aren't identified as being at risk, then it's a pretty good bet they don't have sleep disordered breathing. But it's certainly used as a screening tool. Other things that can be used is looking at the size of the airway, what's called the Mallampati score, and also the tonsil size. For every point increase in the Mallampati score, the odds ratio of having sleep apnea increases by 6-fold. For every increase in tonsillar size, the odds ratio increases by 2-fold for sleep apnea. So these can be indicators of at-risk individuals. Now, again, an example of some of the problems that we have is we know that patients who are more class 2, who have a retrusive mandible, then those statistically are associated with sleep apnea by measurements that orthodontists use. But the actual differences are in the range of 1.5, 1.6 degrees, which is not clinically significant or diagnostically useful. Now, for 1.5, 1.6 degrees, you only can measure that, but you can't really see it. And you certainly can't diagnose from that. And evidence for a direct causal relationship between the facial type and sleep disordered breathing is unsupported. This was a meta-analysis combining data from several studies. So you can't say somebody who's a bit more class 2 is going to have sleep apnea, and vice versa. Not every person with sleep apnea is class 2. And again, it's an example of statistically versus clinically meaningful. Yeah, it was statistically significant, but clinically 1.5, 1.6 degrees, totally meaningless. You can't really see it, and it doesn't diagnose for the condition. Now, the other claim that's made is it's going to affect facial type in ear, nose, and throat patients. So if an airway is congested and results in this altered posture and aberrant growth, causing a long facial type, an open bite, and so forth, wouldn't you expect those in the ENT clinics to demonstrate more of these characteristics? Now, this has been an argument for a long time. So this paper's back from 1958, and they found the percentage of children with various malocclusions was basically the same in the patients in the ENT clinics as those without respiratory problems. So there was no difference. Now, some would say, well, that's an older paper. It's not significant or relevant anymore. Well, this is a very recent study from the Journal of Dental Sleep Medicine. They had 90 consecutive children aged 5 to 10 referred for suspected sleep disordered breathing. 15.5% of them had a posterior crossbite where the top jaw is too narrow relative to the bottom. About 5% of them had a protrusion greater than 7 millimeters, so a significant protrusion. But those numbers are no different to what you find in the general population that aren't suspected of having sleep disorder breathing. So they're no different, or certainly not detectable. And as I said, this has historically been around for a long time in orthodontics. It's not new. They were discussing it, this article, back in 1938. And in fact, they're talking about a gentleman called Kingsley, well known in orthodontics, was one of the first writers back in the late 1800s to talk about mouth breathing. In 1901, Mayo Collier described the facial type of a mouth breather. And a gentleman called Alfred Rogers introduced the concept of myofunctional therapy back in 1918. So these are not new concepts. Orthodontists have known about this and discussed it for a very long time. Back then, back in the 50s and 60s and 70s, it was discussed again. And now it's being resurrected again, particularly and directed more, unfortunately, through social media to the general public and general dentists. And it's an example of making sure we remember our history. As Winston Churchill famously said, "Those that fail to learn from history are doomed to repeat it." Pardon my poor Winston Churchill imitation, but it's an important saying. Except Winston actually had forgotten maybe that the Spanish philosopher George Santayana had said those that who cannot remember the past are condemned to repeat it. Except both of them had forgotten that Edmund Burke back in the 1700s said, "Those who don't know history are doomed to repeat it." So it seems we're destined to repeat this saying over and over again. But it's worth remembering, because if we forget why we stopped doing something, we're just going to repeat the same mistakes again. And I like Edmund Burke. He was an Irish politician in the British Parliament. Bit of a pot stirrer, but he had some great sayings. And one of his that I really like is, "The only thing necessary for the triumph of evil is for good men to do nothing." And what we need is the good information to be put out to our patients, put out to the public, not those with a vested interest in selling appliances or techniques. Now, unfortunately, the poor lip incompetent person, often termed a mouth breather, is seen as the dullard in society. If you've ever watched the show Stranger Things, the character 11 or Elle in the first 2 seasons calls somewhat a mouth breather because they're being rude and being an idiot. She terms them a mouth breather. So they're maligned, the mouth breathers, those who are lips apart. And it's been claimed that what we should be doing is taping their mouths shut, this new treatment, except it's not new. And there's some people, maybe we would like to tape their mouths shut, but it's not a new concept. It's actually been around for a long time, but it wasn't effective. And we've also got to consider, well, what is the cause? Because they're claiming that this mouth breathing is leading to a change in postures and facial growth. You'll end up with a long facial type, an open bite facial type, a narrow face, and so forth. Or you could take the argument that those with the long, narrow facial type are more likely to be lip incompetent or mouth breathers. So let's look at the evidence about that. Now, some of the studies that are used to support the argument that the airway affects facial type was done in monkeys by a gentleman called Harvelt. He took plugs, blocked up the monkeys' noses, and they changed their breathing mode. They had to breathe through their mouth. Now, there's some problems with that, but it's a classic study published back in the late 70s and 80s. He blocked the noses of rhesus monkeys and observed them for 2 years, and there were some traits that were common. But what happened is the monkeys all adapted differently. And we've also got to remember it's an extreme. But they had to maintain their mouth open at least some of the time. But some of the animals would breathe rhythmically. They'd open and close their mouth to be able to breathe. Others would leave their mouth open all the time. Some would posture their tongues in different ways. So the animals actually ended up with a variety of different bite problems. Some would have a class 2 bite where their jaw was back or the teeth were back. Some would have class 3 bites where the top teeth were behind the lower teeth. Some would have teeth apart at the front. Some would overlap and be overlapping too much. So there was a variety of different types of bites. And even though that's sometimes used as evidence for this relationship between airway and facial growth, Harvelt himself said it's unlikely that a correlation can be established between mouth breathing or oral respiration and a particular type of bite or dental malocclusion. It's also we're looking at what's called the levels of evidence, the pyramid of evidence, and animal studies are right down towards the bottom. And there's a reason for this. Firstly, it's an animal study in an animal that looks very different to humans. Some relationship to humans, but very different facially. They've got protrusive muzzles, more teeth than humans. but they're also obligatory nasal breathers. You block the nose off, you could potentially kill the animal. You have to do it gradually, introduce it over time for them to adapt. Secondly, it's something that is not natural for an ape, and certainly not natural for anyone to be blocked off 100% of the time, all the time, for 2 years. Now, there are occasional cases where you get people suffering from corwanal atresia or pharyngeal flap surgery that has gone wrong. They're extremes, and that's not the normal patient, who is occasionally obstructed with allergies and other issues, but can be quite happily breathing through their nose still. It's also one of the discussions for the possible reasons why humans suffer from sleep apnea more is this change in facial type, that as the mandible has changed and the hyoid position has changed, it's allowed other features to develop over time that humans could develop the power of speech. But it also meant that we were in a position where our tongue could drop back and block off the airway and potentially at more risk of sleep apnea. So we are able to develop speech sounds, apes are not. So despite what the movies say, the apes are going to start speaking and taking over the world. But unfortunately, over evolution, more recently, we seem to be perhaps devolving a little. In fact, this is the first generation in Western society that may live or not live longer than the previous generation because of the effects of our diet and obesity. So the children may not live longer than their parents, and that's a scary thing. And it's mainly lifestyle and diet. In fact, we're devolving. The group Devo from the 1980s, and I love my 80s music, basically were named after the de-evolution of what they felt of American culture. And I love my music so much, my 80s music, that I even occasionally dress myself and my staff up in these sorts of things, which they love to do. At least they tell me that. So anyway, let's have a look at what's happening with this lip apart thing, because everyone who has their lips apart is often assumed to be a mouth breather. But is that actually true? And is that something that's wrong, or is it a natural part of development? And a gentleman called Peter Vig, who's one of the world's experts on airways in orthodontics, and I had the good fortune to train with Peter Vig at the University of Pittsburgh, where my thesis was on facial type or craniofacial morphology in patients with obstructive sleep apnea. But here in this earlier study was looking at what happens with your lip positions. Now, are your lips apart? Is that normal? And what he found was that in younger children, their lips were apart. It was pretty normal, up until about the age of 9. And then between the ages of 9 and 13, their lip growth started to catch up. So these kids were growing vertically facially, but their lips couldn't reach the distance. But then their soft tissue growth started to catch up. So most kids between the ages of 9 and 13 whose lips are apart, their lips will start to come together without doing any treatment. So a lot of these treatments that are claiming, oh, you better do something about that at ages 9 or 8 or even earlier, otherwise they'll end up with problems, those lips will start to come together for most of them with doing nothing. It gets better naturally. Another study that was done by Dr. Vig, along with a very famous orthodontist as well in David Sava, they looked at 3 groups, those with normal faces who had their lips together, those who had normal facial proportions but who couldn't get their lips together at rest, and those with truly long facial types. And what he found was there was no difference in nasal airflow. In other words, they could breathe through their nose equally in all groups. So if your lips are apart, it doesn't necessarily mean you're breathing through your mouth. So that assumption that somebody's lips apart, they must be a mouth breather, isn't true. A lot of them are breathing through their nose quite happily. And another very famous orthodontist, Bill Prophet, in his textbook, Contemporary Orthodontics, he put a lot of this information together from people like Peter Vig and Donald Warren, one of the other great experts in airways. And he's plotted here the normal facial types in that purple color and the long facial types in the green color. And basically, the majority of both groups quite happily breathe through their nose, even the long facial types. But there is a tendency for some of the long facial types to breathe through their mouth. So why is that? And Peter Vig also looked at this. And he found that the lip incompetence, or lips apart, is associated or correlated with breathing through your mouth, but not with nasal resistance, how hard it is to breathe through your nose. So what does that mean? Well, basically, if you're going to breathe through your mouth, you are going to have your lips apart at least some of the time. So it makes sense it's associated with it, because it has to be. But those with high nasal resistance or congestion weren't always breathing through their mouth. And what we're talking about is the important thing of what happens at rest. So mouth breathing at rest he found was behaviorally based. It was a habit rather than airway based. So some of them would have high nasal resistance but still quite happily breathe through their nose, and others wouldn't have any problems with nasal resistance but would choose to breathe through their mouth. So those with the longer facial types and were lip incompetent, some of them choose to breathe through the mouth. They don't have to. So that, going back to the chicken and the egg argument, goes, yeah, you know what? The chicken did come first. The facial type came first, not the airway causing the facial type. But again, the claims are made, your child cannot breathe well through their nose, sets up a chain of events that severely impacts not only their health, and that certainly can be true, but also the way a child's facial features develop and ultimately the way they look as an adult. And that's scaring people. It's saying that they'll all end up long facial types, lip incompetent. Well, firstly, is that necessarily a problem? Because there's some extremely attractive people who have their lips apart and long oval facial types. Scarlett Johansson is gorgeous. And they've also said that they're dullards. You know, this idea that the long facial types are idiots. They don't perform mentally well. Well, whether you like Facebook or not, you can't say Mark Zuckerberg's not intelligent, an extremely intelligent person. And conversely, is everybody who's a short facial type, you know, are they brilliant? Well, actually, this gentleman is very, very talented. But there are people with true long facial types. This one would be considered lip incompetent, mouth breather, what was often called in the 60s and 70s an adenoid's face, claiming that the adenoids was the cause of this. Except when we look at this patient clinically and also even just on these radiographs, which is not the best way to look at these sorts of tissues, but there's no adenoids there. He had no history of adenoids or tonsil problems. But he does have a larger gonal angle, which to an orthodontist is an indicator that that might be a long facial type, that he's going to grow longer as he gets older, particularly in the boys who keep growing into their late teens and early 20s. And then at 13, we can see, well, its teeth are still kind of holding up okay, but those lips are getting a bit further apart. And then once his facial, that big spurt of growth occurs in the mid to late teens, we can really see that's impacted on his facial growth and his jaw and tooth position. But again, when we look at the airways are fine. He never had any airway issues, no adenoid tissue, no tonsillar tissue to speak of, but he does have a significant gonal angle circled in the purpley color there. Here's a true long facial type, and that was from genetics. That's from his family background. That's how he was going to grow. But unfortunately, Dr. Google says, you better go and get some treatment because there's a host of unpleasant symptoms and problems as you get older if you don't treat it. And as I said, they're mixing up some real concerns. If they've got a true airway problem, there can be some real health concerns there. But don't drag facial type into it. Now they'll say they can lead to permanent skeletal deformities because it promotes growth of the upper jaw. It will result in a large overbite and a gummy smile. So let's have a look at some of the information regarding adenotonsillectomy, removing the adenoids and tonsils in children with obstructive sleep apnea. And this was a group of children aged 5 to 8 in a randomized clinical trial. They've randomized some of them to getting their adenoids and tonsils out, and the other group didn't. And they watched what happened. And in those that had their adenoids and tonsils removed, almost 80% of them, it improved or normalized their sleep studies. It cured their sleep apnea. That's great. 4 out of 5. Except almost half of those that had no treatment at all also got better. So really, there was only about a 30% benefit. Some of them will get better anyway, which happens with growth. Lymphoidal tissue, which adenoids and tonsils are part of, spike in growth in that early teen region, and then they start to drop off and shrink down over time. So some children definitely should have the adenoids and or tonsils removed, and others may need other interventions or watchful waiting. But that's up to the specialist to determine, the ENT specialist. The effect of adenoidectomy or adenotonsillectomy on occlusal features in mouth breathing preschoolers. In this study, they found neither the breathing pattern nor the surgery had any effect on occlusal features in this group of children. No change. Now, this one was a combination of data from in medicine. It was basically a meta-analysis. They said it had significantly narrower posterior maxilla, narrower upper jaw, significantly of 0.94 of a millimeter. Not even 1 millimeter. But they at least made the statement that as the effect of surgery was limited, other treatments such as functional training or widening should be considered. But it's significant, so people quote it. But that significant change comes from, this is the combination of data. 2 of the studies find no difference whatsoever. It's mainly, and most of the weighting comes from this one study, which is a classic paper in orthodontics by a gentleman called Linda Aronson. A couple of the papers here, but children treated with adenoidectomy had longer facial types in the first type and tended to improve after the surgery. But there were some that were excluded. So there's a little bit of bias going on in the data. And again, Bill Prophet has talked about that in his textbook, where they start with higher angle facial types by about 3 degrees. Now, is that cause effect, or is it even clinically significant? But even if we just look at the data, they improved after surgery. They reduced by 4 degrees. Except naturally, controls also reduced 2.5 degrees. So there's really now only about 1.5 degrees difference between the 2 groups, which clinically you can't determine. You have to measure it. And is that because of surgery, or was that going to happen anyway? This study was looking at 55 severely obstructed children at ages 6 versus 55 nasal breathing children, normal breathing children. They had longer faces by about 4 degrees. But the growth rotation or angle improved with no treatment. They were getting better anyway. Now, unfortunately, some of these children turn up with ENT problems. This particular young girl had significant allergies, problems breathing through her nose. She's got some minor orthodontic problems there as well, so there's a blocked out tooth. But she'd been to an ENT, had a consultation, and they'd initially tried some reversible conservative nasal sprays. Wasn't really responding too well to that, and so suggested, even though she didn't have overly large adenoids, that they should be removed and have her turbinates removed, the bones in her nose. Really fairly significant surgery. Now, at that time, the mum and the child and the dad decided, no, we'll just watchfully wait. They made an informed choice not to do anything at that stage, and they involved the daughter in the decision as well. But I can show you her because this is my daughter. She was not even 9 years of age at this time. I did some orthodontics. I did open up some space for a blocked out tooth in the upper arch. You can see where the gap is. She had a bit of crowding, so I reopened the space there. But other than that, she hasn't had any ear, nose, and throat surgery. And from a facial perspective, she's in the normal facial type. Bit of crowding, but normal facial type. Here she is, not quite 11, waiting for that tooth to come through on the top still, but overall, still no surgery, still growing normally, no difference in facial type. And in fact, I'm kind of biased, but I think she's kind of cute. Here she is at not quite 12, still no surgery. Teeth are starting to come through. A couple of them are a little bit wonky, a little bit crowded. I can sort that out. But facially, fine. Not becoming a long facial type, not lip incompetent, not the mouth breather. And eventually, it was annoying her enough that she decided, yes, I'll have the surgery. She had the turbinates removed, the adenoids, small amount of adenoids removed, helped improve her quality of life in terms of breathing through her nose. Significant surgery. She was a week and a half off school. It's not a fun procedure to go through, but it's improved the quality of life of breathing through her nose. But during that time, that 4 years, no change in facial type. It hasn't affected her facial growth. So we'll go back to some research, and this one's comparing sleep disorder breathing and sleep apnea in children, ages 4.5 to 5. They found upper obstruction is associated with mild but significant cephalometric modifications in children with snoring. But again, they were mild. But whether it's genetically determined or influenced by the inset of snoring remains to be seen. So they're going back and being more honest in this one. They're not claiming it. You can't prove cause and effect, but again, statistically significant is not clinically significant. This one looking at the effects of adenoidectomy on dentofacial structures, 6 years follow-up, 13 had surgery, the rest didn't. The sagittal and vertical changes, in other words, the front to back and vertical changes of the facial type, are not related to nasal resistance. Didn't have an impact. Adenoidectomy does not affect facial type and malocclusion. This one looking at sleep disorder breathing in young children. looking between the ages of 4 up to 12, dentofacial development in snoring children is not changed by adenotonsillar surgery, regardless of whether their symptoms improve or not. So if snoring persists or relapses, then perhaps widening the maxilla could be considered. That's based on some other data, which we won't go into today, but that's very unreliable. It can have an impact in some and have no effect whatsoever in others. So when it's indicated for other reasons, it might be considered. This one was looking more in 3D, three-dimensional facial scans. They found significant differences of 0.3 of a millimeter and 0.9 of a degree. You can only measure that with very accurate software. You can't see it, you can't diagnose from it, and you're certainly not going to go and have surgery for 0.3 millimeters change or 0.9 degrees. Again, looking at children ages between 3 to almost 12, soft correction was noted for anterior open bites. So those that had their teeth apart at these younger ages, a lot of them improved with no treatment whatsoever. So if you've got a child whose lips are apart or their teeth are apart and their ages, 5 to 10, talk to an orthodontist and ask them, and they'll be aware of which ones may need an intervention and which ones may not. There could be a habit, or it could be something that could self-correct. Or maybe it's not the appropriate time for treatment, but they'll give you the best information. But a lot of these open bites will improve with no treatment, and in fact, the bites will usually deepen, which means they overlap more. And the habits, allergies, or breathing disturbances at age 3 had no association with their bite problems at age almost 12. So now we'll talk a little bit about some of these oropharyngeal or myofunctional exercises, which is a different thing. It's not an appliance, it's throat exercises for different conditions. And these are, had some research, and I think worthy of more investigation. So this was 31 subjects in a randomized clinical trial for 3 months of exercises, 30 minutes a day versus a sham therapy. So these exercises work on the tongue, the soft palate, the pharyngeal walls. Basically, the muscles enveloping the airway. And if you've got flaccid muscles, the theory is that they can collapse more readily, and therefore you're getting sleep disorder breathing or sleep apnea. You stop breathing during sleep. So if you're trying to improve the tone of these muscles, then perhaps they'll collapse less. So that's the idea behind it. And the exercise group reduced snoring. It improved their daytime sleepiness, and their apnea-hypopnea index, or the number of times they stopped breathing during sleep, improved. Didn't get cured, but it improved. So we can see it reduced down in the apnea-hypopnea index, almost halved. That's still not cured, but it is improved. Another study, exercise group and CPAP, which is those masks that pump air in to try and keep the airway open. Very effective appliance, but some people just don't like wearing them, but very effective, but you've got this little pump on your face while you're asleep. When they compared the two groups, they found and looked at improved quality of life scores, the apnea-hypopnea index improved again. Didn't cure it, but it improved again. But we also need to consider long-term what happens. Another study, and as I said, don't confuse these exercises with myofunctional appliances. They're different things. But they found in this meta-analysis where they combined the data, the exercises appear to decrease the apnea-hypopnea index in children and adults. But there is more research required, and particularly, in my opinion, longer follow-up. Now, there's also these little nasal dilators that you put on your nose, and it kind of widens what's called the liminal valve. And the liminal valve is the greatest area of constriction for most people. It's just around about roughly a centimeter in from the opening of your nose. So this kind of flares that region of your nose, and it does help. If you just widen that yourself, you'll notice it's a bit easier to breathe. But does it help with sleep apnea? And that's what this particular study looked at. They found the nasal dilator group had no changes, whereas the exercises improved again. So it didn't cure it, improved. So we're working the muscles out, and we know that if we work muscles out, we can get them bigger and stronger and more toned. That's a great effect. It can work. But what if I stop? Well, we know if we're not exercising, that muscle starts to go back down. We need to maintain the exercise to keep muscle tone. So perhaps if we're not doing these exercises long term, we'll just go back to where we were. So it'd be nice to do a sleep study, comparison between those with and without, and see if it's got an effect, and follow them long term. Let's say the young lady is the control. She's had no treatment. The young man is having these oropharyngeal and tongue exercises, and observe them during sleep and see what happens. Oh dear. Well, I don't think that's probably going to be the effect, but does kind of support the idea that some of the best commercials around the world usually are related to beer commercials. So I'm sorry, but that's obviously meant a little bit tongue-in-cheek. But I do like that video, and I think it makes a little bit of the point that, you know, if you're going to maintain an effect on a muscle, it needs to be maintained long-term. So my suspicion would be that these exercises may have an effect or an improvement, but you would need to keep them up to maintain that improvement. There's also another claim about Buteyko breathing. It's a breathing style developed by Professor Buteyko, initially as a treatment for asthma. But it's a series of reduced or breath-holding exercises that focus on nasal breathing and relaxation. And relaxation is a good thing. You know, from a well-being point of view, we know relaxation is helpful. But if we're looking at reviews on this, and there's not a lot of information, but in Australia, the Australian government rebate, for example, looked at these natural therapies and whether it is deserving of a rebate. Does the evidence supporting this particular therapy? And so far, they found no good medical evidence that the Buteyko method confers any health benefits. If we're looking at breathing exercises in general, one of the best sources of information in the medical and dental literature is what's called the Cochrane Library. And this one is on breathing exercises for children with asthma. And they could draw no reliable conclusions concerning the use of breathing exercises for children with asthma in clinical practice. Now, that's not to say exercising such as swimming or any cardiovascular exercise for that matter. That can have an improvement in terms of reducing dependence upon medication. So it's been shown that it doesn't cure the asthma, but it can improve their dependence upon medications. But things such as Buteyko breathing, there's no evidence to support that it's helping. But unfortunately, when you go to Dr. Google, there's lots of claims made again, you know, and other claims that are also made is that if you have teeth out, then you'll stop breathing much more often. And unfortunately, again, that's a concern. It's alarming parents and families. Now, if we're having a look at what happens, then, you know, extractions do affect arch width changes, how the shape of your jaw is. But that's the whole reason it's being suggested in the first place. You know, the distance between the molars, the intermolar width, will be greater in the non-extraction group. And the distance between the canines and premolars will be greater in the extraction group. Well, basically what's happening there, if we've got somebody who's crowded, this is looking at the lower arch, for example, and we extract two teeth, the two canine teeth, they're normally closer together in the narrower part of the arch. The molars are further back, so they're in the wider part of the arch. But if we've taken teeth out, we're using that space to unravel the crowding. So we're going to move the molars forward and the canines back. So the molars will move forward into the narrow part of the arch. So the distance between them will get less because it's sitting still in the arch form. And the canines will move back into the wider part of the arch. So that's what we would expect. You haven't actually narrowed the jaw at all. In fact, often the arch width is wider because that's what the orthodontist in the controlling of shaping of the arch wires or aligners has dictated into their treatment. But that gives them room then to unravel the crowding and line teeth up. And that's also a minority of cases. The research in Australia, there's a survey I conducted in 2013, and in the process in Australia now finds that the average extraction rate's about 20%. 80% of cases in Australia are treated without extraction of adult teeth, apart from wisdom teeth sometimes. But other than that, 80% of cases are treated without extractions of adult teeth. But when they are, it's indicated for more marked crowding or for the bite, but it's not actually reducing space for the tongue, which is one of the claims that are made. So there's usually no significant differences in the buccal corridor widths, which is the space between the teeth and the cheeks. But unfortunately, if we go back through the history of orthodontics, we went through phases of non-extraction, which started with the father of orthodontics, Edward Angle, who said we'll never extract teeth. He based that on a couple of things: the Apollo Belvedere, this statue, and what he called the Old Glory skull. Now, he considered the Apollo Belvedere statue to be the ideal profile. Now, nowadays we would think, nah, that's not probably the profile we're aiming for, but in terms of the lip position. But if we're also looking at his Old Glory skull, which had all the teeth lined up, all pretty good, all the wisdom teeth, everything's fitting into the jaws there. But there's no way you could fit those teeth in that Old Glory skull into that facial type. The Apollo Belvedere would have much more protrusive lips. It's a very different facial type and person. Couldn't happen. So if we look at the history of orthodontics, as I said, started out barely extracting teeth back in the 1900s, early 1900s. 6.5% was the extraction rate in the United States at that time. Now along came two very famous orthodontists as well, Charlie Tweed in the United States and Raymond Begg in Australia. And both of them had seen problems with the stability of some of their cases where things had crowded back up again and been a real problem. And so for different perspectives, one from poor stability and one from looking at what happened in the Australian Aboriginal with interproximal wear, but overall not looking too bad. But they also have much broader arches and different facial types. But for both reasons, they decided we need to make more space. So we'll extract teeth. And unfortunately, that led to, by the 1960s, that in the United States, 80% of the time, you would be recommended to have adult teeth taken out. Now, unfortunately, the pendulum swung way too far to the other side. From never extracting, as Edward Angle dictated, versus extracting 80% of the time. And then some problems were seen in terms of sometimes over-retracting the teeth, flattening the lips off too much. And we went, wait a minute, do we really need to do that? And it slowly over time has reduced. You know, that was a mistake. And so the average extraction rate in the United States is around about 15%, in Australia about 20%, and in Europe a little bit higher than that. And it's one of the most researched topics. I write a blog on various different topics, but this was the highest organic research, is people looking for, do extractions cause sleep apnea? Is it going to affect my breathing? Is it going to stop me breathing more? Well, there's a number of studies on this, but this is the biggest one. It was 5,500 subjects matched for either having 4 teeth out or no extractions. Half of them had 4 teeth removed, the other half had none. And they will match them. And they found the incidence of sleep apnea in the two groups was basically the same. Statistically looking at that, and clinically, there was no difference between the two groups. Extractions were not causing sleep apnea. Roughly about 10% of people as adults have it anyway. And those patients would have been treated at times when the extraction rates were much higher than they are now. So a lot of those patients wouldn't even be treated without extractions nowadays. So it had no effect. Now don't get me wrong, breathing's important. Relaxation's important. It's a health benefit. To relax and meditate is a known helpful, has helpful impacts on our life. I did martial arts. I did judo for 15 years and other martial arts. Every beginning and end of every session is always in meditation and breathing. That diaphragmatic breathing, slow deep breaths in through the nose and out through the mouth, and feeling your body relax. It's helpful for mind and stress. So the truth is out there, but it depends on who you ask. When you're wanting truthful information about these topics, it is difficult. We do need to talk to experts. The experts in facial growth are orthodontists. The experts in airways are the ENT specialists. We can work in concert. We can help screen for airway problems. But don't bring the argument that being nasally obstructed some of the time, or even significant obstructions, is going to have a major impact on facial growth. There's a lot of good health benefits to having adenoids and tonsils removed, but for other reasons other than facial growth. So thank you for your attention. I hope that's been helpful, and I appreciate you listening and perhaps sharing this with others. Thank you very much.